Well, hello, everybody. Good afternoon or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I am the managing editor for BBC Exhibit Hall. And so I'd like to welcome you all to today's live webinar, which is hosted by Roji Health Intelligence. And this is actually part two of a three-part series titled Your ACO Guide to Targeting Cost with Data-Driven Strategies. Today's session is titled Strategies Supported by Claims and Quality Data. A few items of note before we get started. Everyone's joined in listen-only mode. This is a traditional webinar format, so you don't need to worry about muting yourself or turning off your camera or anything. We can't see or hear you. But we do want to hear from you, and so we are going to have time for some Q&A towards the end of the presentation. At any point throughout the presentation, you don't have to wait until then in order to ask your question. So you can ask it at any time using your control module. There's a little area for questions, so drop it in there. We're going to get to as many as we can during the allotted time. Now we've got a lot of material to cover today, which I'm sure Terry will tell you about in just a second. So if we might have a lot of questions come through, if we don't get to yours for some reason, someone will reach out afterwards and make sure that we answer your question for you. So even if we're wrapping up at the very end, go ahead and ask it. Finally, the session today is being recorded. So what's going to happen is you will receive an email when we're done, maybe about an hour or so after the fact, and there'll be a link to the recording and also where you can download the slides from today. And that way you can follow along, you can review it or share it with colleagues. We hope that you do. So without further ado, I'd like to introduce our host, Ms. Terry Hush, and she is the CEO and co-founder of Roji Health Intelligence. So welcome, Terry.
Thanks, Garrett. And hello, everybody. I'm really eager to be here talking to you again. And we'll do a little bit of a review of the last or the foundation series on this one too, but there's a lot of stuff to talk about. So I won't spend too much time getting into it. A little bit about Roji. We provide value-based care technology. We're definitely in this space with both quality reporting, quality data, and cost evaluation. We have products that are technology-driven and data-driven to help our provider clients get to risk. Before I start presenting, I'd like to find out a little bit about how you're using quality data right now, because last time we talked about some quality data, but we didn't talk about quality data in general. So once again, my bearded colleagues get to be the significant depiction of the question here. So if you're snoozing on option A of how you use quality data, you might be using quality data for just quality reporting. So you would answer that on your poll. If you are flying with some quality data, you can say B, select B, we use quality data for improving outcomes and costs. And if you're frankly kind of confused about what kind of quality data we'll be talking about today, just say so. What quality data? So Garrett, are you
Okay,
taking
so this I am. So this is up. It should be up on your screen now, and of course this is anonymous, so don't worry. And we'll show the results here in a moment. That way you can kind of see where you stack among your colleagues, which is kind of interesting. So we'll give it a second for the results to come in. And this is, of course, a choose one that that best applies. And we'll have another polling question a little bit later as well. So it'll be kind of in the same format here. So looks like give it another 10 seconds. 5, 4, 3, 2, and 1. And let me go ahead and share the results. Okay. Looks like 100% of the respondents said we use quality data for improving outcomes and costs.
Wow. Okay, well, that's really interesting. We'll have to find out more about that as we go forward. And by the way, these are all the same bearded collie. Just so you know, this is my puppy.
Different phases, eras.
So as we're getting in deep in data today, I think one of the important reminders I'd like to leave with you is that we're going to be exploring the boundaries of what you might be using in your data. So be careful not to prejudge how you might use some of this data. Don't eclipse your vision on that. So let's review some of the cost concepts that we talked about the first time. First of all, total cost of care and total per capita cost are how payers and patients are generally measuring your affordability. And total per capita cost is just a derivative of total cost of care. It includes everything. Now, some value-based payment models will call something total cost of care and make some exclusions like ancillary services, or even if it's a primary care cap, then they would exclude non-primary care based services. But generally, when you're measuring total cost of care, you're measuring all of the services that are provided to the patients in the population that is covered. So why, if you're doing cost management, can't your action plan be as simple as, well, just reduce total cost of care? Because it doesn't give you any information about how you would do about that, how you would go about doing that. So at the total cost of care level or at the capitation level, there really are only two tools available to you. You can cut services. You can do it on the front end by pre-authorization or on the back end by referrals, or you can enforce benchmark cuts to physicians if they go over the mark. Neither of those is a very attractive solution and really doesn't get at reducing costs. It simply artificially lowers the services and costs that are tallied up. So what you really need to look at this path as is of the supports that are along this cliff to be able to reach better cost performance. Total cost of care or total per capita cost is not an actionable concept, is what the bottom line is. It doesn't provide any detail on what is driving the cost. And like these pelicans going after a fish, they have no idea how they're going to reach that goal. They just want the fish. The creating of interventions for cost control is one of the things that we'll focus on today. And there are basically four things you need to keep in mind. Understanding the available data or the data available to you at the point that you're doing the measurement, targeting projects to reduce total cost of care, developing a claims plus APP plus quality measured data to provide some clinical data, and then focusing on that data and what it will do to support your projects. And then massaging that data so you actually have a point of comparison. And we'll go into all of these. But what you don't want to be doing is kicking air. It's a great thing, pretty picture, beautiful form, but there's no point. And the point is that you must be able to have the data and a plan of targeting in order to actually accomplish something in your cost performance. So last time we talked about easily available data sources for ACOs. Well, claims data you get, APP measure response data you have to compile. A lot of ACOs, however, are not using the maximum amount of certainly the claims data. The APP data is new, even if you're actually doing APP reporting this next year. And so we have a long way to go in actually using the best tools that we have for cost performance. So what's easy about easily available data? Well, you get it automatically as part of other activities, or you compile it as part of those activities. So you don't have to do any special things to go and find it. Claims data identifies patients with diagnoses. APP measures provides the values that you have with risk, and for meeting your quality performance. QRDAs are not quite as easy as some methods of, or some formats of delivering the data. And in any of these, you are looking for the trend in control values over a year, the patients with the most problematic values. So you're doing a lot of sorting of this data um, to be able to use it wisely. Missing information in data from claims includes any clinical information outside of the diagnoses. That's a serious gap that this lizard is probably unable. I don't know. Do you think he can make it? He looks kind of on the edge there, and I definitely don't think that he can bridge that gap. The other missing aspect of claims and what it won't drive is any predictive patient risk. It will give you what has happened in the past, but because it's lacking the clinical indicators on the patient status, you can't use it to figure out what's going to happen next to those same patients. Depending on the payee, it may be difficult to identify all the providers in the claims. They may be identified by groups and not by individual providers. And you can't find the patient status within the conditions. Missing information in APP data is often driven by the format that data is collected in. QRDA ones limit the data to the measure specific requirement. So you may be focusing on a population with diabetes, but all you're going to get are the A1Cs on the QRDA one. And if a patient, depending on the EHR configuration of the QRDAs, if you have a patient who would have met that measure, you're not going to find any value associated with that in a QRDA. So you'll be missing patients with who didn't show up, for example. They won't show up in your pool. Patient with diabetes. So it will make it hard to manage an entire population based on the quality data. APP reporting using Medicare CQMs, the ACO may be using Medicare CQMs because they have really no common systems and they're going to have to input the data, and they figure that Medicare CQMs will be a lower level or lower quantity of input required than other forms of APP reporting. So again, you may be artificially truncating the amount of quality data you get, and again, you will only get it if you're doing input. You will only get it for the particular measure response. And then, of course, there's a big question about what longitudinal data will be coming through on the APPs if they are limited to measure type responses. Those data limitations degrade your opportunities for pursuing any kind of intervention in costs. And basically, what the kinds of limitations are related to how old the data may be. Claims data is famously old. It is out the door 3 or 4 months after, and that's not accounting for the gap in the billing. And so therefore, it's hard to create current projects based on some of that data. The content of the data is limited. The trended values over time, because they're not there, will not allow you to look at whether patients are improving or not. And all of that information reduces the risk information you're able to compile on patients, and then the interrelationships of clinical data that your physicians may benefit from knowing. So this is also of less value to feedback to clinicians. It's simply a check the box kind of program. If you're going to do really meaningful cost performance improvement strategies, you need a lot more data to feed that. So you need a wealth of information that is going up to populate all of the different indicators that you will be tracking as far as patient status. And those opportunities give you a lot more opportunities to do quality projects. There'll be more risks, more conditions, more effective patient focus, stronger clinician engagement because you can present something that's relevant to clinicians. And you will also be able to make a higher efficiency data aggregation operation. You're not picking and choosing. You're not using staff to do it. You're using electronics to gather all of the data on the quality side from EHRs and be able to port it over to a database that can be manipulated. So what is that quality data that we're looking for? And here's a great bearded collie. You know quality when you see it. This data point diagram of this bearded collie. I see the extension. I see the health of the structure by the way his feet are positioned. I see the level back and all of the things that would speak a standard. You see those same kinds of things that you do in a quality diagram. You see the patient health status. You see the clinical indicators of disease, whether or not those are in the patient is in some point of exacerbation of the condition or not. You see laboratory and diagnostic tests and how those are aligned with the patient health status. Multiple diagnoses, problem lists are available. We collect problem lists from EHRs, show old problems that may not be on the horizon that could cause problems in the future and are definitely part of a risk assessment. You see prescribed drugs, so you know what drugs the patient should be receiving, and you also see treatments and referrals. That's just about everything that is on the quality end of an EHR. And that quality data allows you to go two paths in targeting costs. One is a clinical quality path by improving the conditions of patients with chronic disease, reducing the variation of procedural or identifying observations in the clinical procedures that are a problem. It allows you to identify future cost drivers because of diagnoses that are appearing in the EHR that you may not be aware of in claims. And it also, there are many ways of identifying through the data on quality various health equity issues that are coming up for patients. On the cost variation, you can compare procedural costs very easily as long as the episodes in which you are using are clinically designed, meaning they're not a market basket of procedures. They are specific clinical procedures for a purpose that is alike across the entire group of procedures. They also help you identify the current cost drivers from those procedures. You can easily move into the case history that underlies that dot on the graph and identify what is happening in cases that would either lead you to exclude the cases from the analysis of the cost variation, for example, trauma cases, or identify a problem in practice that you can work with your physicians on correcting. So what data is required to pursue these paths? Well, claims data is going to be required because there are a lot of services outside the view of your participating providers in an ACO, and so you need to understand what else is happening to the patients. You won't always have the clinical information on those, as you know. You will also need to have all patient diagnoses, whether or not there was a claim, if you want to pursue clinical path. You will need vital and clinical values for all quality measures, prescribed medications, and referred service. These are the bulk of things that you're actually going to deploy if you start interventions on the quality path. And we'll go into a couple of what those are. On the cost variation path, you will need a slightly different variation of the list. You can target infections and complications on procedures, redos, anesthesia, rehab, and SNF costs that you want to include a larger array of services in the bundle, and a way of examining those cases in terms of, let's say, open or laparoscopic procedures or variations that you can see that may be a practice decision or a patient decision to evaluate it on the cost line. So why is the EHR data essential? Well, it gives you all of this data that you don't get any other way. None of these things are really able to be provided in claims. You have the ability to develop a rich clinical pathway and understand where your physicians are on the use of existing clinical or value-based strategies that you've already developed. It reveals the factors that are driving your costs. They drop out of an episode very clearly when you start comparing episode to episode on a patient basis or even on a provider basis. They enable APP reporting for all patients. So you can do a lot more. You can do all patient reporting if you are collecting quality data for all the patients in the EHR. And it provides a detail for validating your costs and outcomes in the future. When you're doing a data aggregation that focuses on cost performance and quality performance, you really have to put a premium on how you're gathering the data to get you the most data that you need for all of your initiatives, and avoid a piece by piece kind of data pull. Every time you go in with a different kind of data pull or a project by project data pull, it's a waste of your resource if you don't already have that data in a database that can be segmented. For APP, we'd advise using QRDAs to fill in other information in the quality measure or the quality status of the patient, but definitely not use that as your primary method or your only method of collecting data for quality reporting. You'll need to survey your practices on the EHRs and identify the issues in advance. Not all practices that are certified can produce a QRDA 1. They can produce a QRDA 3, but they're not necessarily designed to produce the QRDA 1 back to the client. That's an important thing to understand. Some of the systems that aren't certified, of course, are not able to really report much data out, and you may need to use kind of an old-fashioned flat file reporting method. So understanding where your practices are, what your systems are, is going to be an essential part of your overall data aggregation to do anything with costs. And I think you probably can tell right by now that what I'm saying is that your cost performance or your cost exercises are a function of whether you have the data to support them. You'll also, over time, need to consider offering a central EHR or helping practices move on to a fewer common systems so that you can actually manage a data aggregation process economically. But there are 3 essential data types you will always need no matter what you're collecting. You will need time-based labs and other clinical values so that you can see the patient on an improvement arc. And if the patient is a flat line and poor control, you'll need to figure out what to do with that patient to get them in an improved ARC. It's the most important indicator I think that we see in the data is our patients who are not improving and have been that way for a very long time. You will also need to be able to identify clinical events like exacerbations, inpatient admissions. Some of these are going to be in the claims, some of them will be in your EHR. Utilization events that show up in claims, complications in the clinical data will show opportunities to address either clinical issues, pathway issues, or they may actually address patient selection issues, patients who weren't doing well to begin with and yet were put through a procedure that was likely to be maybe of an elective procedure that was not likely to turn out really well and really hit the dollars and poor results for the patient. You'll also need to know their prescribed meds and referrals to programs and services so that you can get them into a population health that is actually generating results as opposed to a stagnant result. Here's some little bearded collie puppies who understand that they really need to focus on the best quality options they have. And in your case, looking at the best quality options for data aggregation, the highest content is going to be in two areas, either a FHIR feed or flat files. Supplemental, you will not have a lot of data that comes through on QRDAs unless they've been programmed differently, but a typical QRDA will limit your data and can be used to meet quality measures, but not do cost performance in a big way. So once your data is collected, then what? Then you want to compare the costs per patient. You want to target patients for targeted interventions with patients for chronic disease and do so in a way that is going to meet priorities that you have and do it economically as well. You don't want to go after a lot of conditions where you don't have volume. You want to address volume first of your patients and critical situations to improve patient care. You'll want to definitely examine cost variation among your specialists. Your specialists may be external. That's a whole different topic about how you would collaborate with those specialty specialists outside your organization, but they are more than willing in a lot of cases to engage in data sharing and projects of mutual benefit, especially if they are a committed specialty to your organization. And then finally, you're going to need to have the episodes identify patient economic vulnerabilities that limits their treatment. So if you see patients in diabetes, for example, that are not improving and are on basic insulin, you have an indication that there's a problem with how the medications were prescribed in that patient could be an economic problem on the patient side. Simply can't afford some of the fancier drugs. You can also take that data and move it up into focus areas. So if you want to do a lot on the quality end that is combined with costs, you're going to be addressing the three big metabolic conditions, and that is diabetes, blood pressure, and coronary artery disease. Heart failure is a special case. There you're going to be looking at whether patients are moving in and out of the hospital, having continual episodes of failure, and are potentially not on the new standard of care for medications. You'll be looking at patients, as I mentioned, with static outcomes, where they never improve over time. And why not? And figuring out what's wrong with either the treatment. Who gave up? Did the patient give up? Did the physicians give up or believe that the patient was really unable to be compliant with a plan, or was there no plan? So a lot of these will come out in the episodes of care as you dig down into each episode. You'll be looking at prescription drugs that are on a lower or an older tier and how often they're used and whether they're appropriate, and looking at both high and low procedure costs. You don't want to put your physicians in a defensive posture by only looking at one end of the spectrum, because you will easily find some interesting variations on the low end of the procedure cost spectrum as well. The key steps to savings in the conditions are going to be creating your core patient population with episodes. Creating that individual patient episode allows you to include the costs, time, and all outcomes related to those conditions. We do not, at Roji, limit those outcomes to the measure that defines that condition. So, for example, on diabetes, we're looking at 5 or 6 different outcomes, including BMI and as well as hemoglobin A1C. We're looking at hypertension because it creates a higher risk on the patient. We're looking at any diagnosis of chronic kidney disease and a variety of other outcomes as well. So you want to be able to track all of the outcomes related to an episode for a patient on one component or one diagnosis. And then you're going to go through a process of applying clinical interventions, because these are clinically driven savings. These are the ones that keep recurring over time by the fact that the patient is improving. And you will prevent exams. So they're very preventive in focus. You'll want to look at their visit profile. Are the patients coming in on a regular schedule, and what does that profile look like over a longer period of time? How are they compliant on prescription meds? Are they on a glucose monitor? Or do you have, if you have patients that are on the hard end of the risk spectrum, have you provided referrals to specialty care or dietary services or self-management programs or any of the other community or other non-provider services that can help them improve diabetes results as well? And are you sharing that data with physicians and groups so that they can see patients and where those patients stand? Is a really important facet of the whole cost management. On the specialty procedures, what you're focusing on is lower cost variation, but it isn't without a look at the notable observations of quality. So for your high diagnosis procedures, you're looking at procedural episodes. Generally, those are framed in time by a different time frame, maybe from the imaging prior or the decision on the surgery, perhaps a month, perhaps 6 weeks before, to the actual procedure, and then some period after that. You may incorporate a 6-month PT process or recovery process after that time. So you're looking at a limited point of time, one that is able to capture redos or complications or patient-reported outcomes of pain, or a lot of different other things that you find in the procedural episodes. And those get plotted on a cost curve by episodes and by proceduralists. So you can see right away in both of those instances, whether you're plotting them by patient or you're plotting them by the proceduralist within a given condition, what is happening on those costs. You can also plot the different approaches to the surgical procedure and determine what you're seeing on the cost curve there, and as well as outcomes. So you are identifying the common attributes of those higher and lower cost cases, one of your analyses, and you're showing clinically notable observations associated with the procedures and measuring the extent of those for every proceduralist and every type of patient. Then you share that information with the specialist. You provide a mechanism for the clinicians to provide feedback on that data. And where it's possible, you create collaboratives to improve the pathways, reduce the complications, and improve results over time. So those are examples. There's no one path to cost performance. They are all about what your population looks like, what your physicians are engaged in, and what tools and data supports these strategies. You have to use the tools to develop your cost vulnerabilities and variations. Simply having a database of all your claims without the analyses doesn't help you get to what needs to be improved and doesn't help you forge relationships either with the community or with specialists that can help that. Once you have that data and the tools, it's really the human process, the human change process, and there's politics and persuasion involved in that. So that's what you can do with quality. I have another part of this presentation that I want to go at regarding data. But before we do, I'd like to know what your 3-year plan is for data. Your choices are you're going to use mainly clinical data. You may have some, for example, the easily available APP data. Or you're going to or do aggregate EHR data. Or a third, this is just too expensive a proposition for you to go further.
Okay, you should see the poll in question on your screen. So go ahead and fill that out. And again, this is anonymous, so you will show the results and you'll be able to see kind of where you stack among your colleagues. So we'll give it another few seconds for it to come through. By the way, if you have a question that you would like to ask for our Q&A coming up, go ahead and submit that as well in the questions module at any point, and we're going to get to as many as we can. Okay, I think most of the responses have come through. We still have a couple coming in, so we'll just give it a couple more seconds here. And we'll shut it down in 5, 4, 3, 2, and 1. Okay, it looks like for those who use mainly claims data, that's 19%. And the aggregate EHR data is 81%. And then we did not have any for the too expensive.
There's progress. I see progress from this, from the variety of webinars that I've done. Really moving forward. That's exciting.
Good deal.
And I'm
All
glad
right.
we have no pigeons.
Yeah, no pigeons.
So I want to talk a little bit about what we see the future of managing costs are. This little outlet screaming for food, I think that he does a good job of depicting the environment that we're entering into right now. He's a bird of prey, so it's either eat or be eaten. Most of the new value-based payment models are focused on risk. They are ACO REACH, primary care flexes are both capitated kind of models. We didn't used to use the word capitated for a while in value-based care. We talked about population-based payments, but I think right now it's out of the bag, and I'm hearing the word capitation over and over again. Specialty care models are beginning to incorporate this too. In the enhancing oncology model, does that. And we're hearing much more about the possibility of global capitation with negotiation of specialty payments within ACOs. CMS in its other business, meaning those who are not in ACOs, those who are still on fee-for-service, are applying total cost of care measures. There are two of them that are applied. The total per capita cost and the Medicare spending per beneficiary, which is basically a total per capita cost. And then there are additional episode-based measures or population-based measures for selected diagnoses and procedures. And I don't know how many organizations really understand what's going on in the MIPS program, but I think what we're seeing is that this is, as they move into the MIPS value pathways, requirements for specialists, the encouragement of ACOs to adopt specialty MVP measures, that we can see that this is starting to move over into the ACO arena. So I wanted to give you a look, if you haven't ever seen this list, of the CMS MIPS cost measures and just see the variety of individual procedures and individual conditions that CMS is developing cost measures for. Look at number 22, diabetes. So we normally don't think so much about the cost of diabetes except as inpatient and exacerbations occur in diabetes. But I think it's important to recognize that these are all on the horizon. So is asthma and COPD. Looking at renal stone surgical treatment, emergency medicine, heart failure. So you're seeing a lot of chronic diseases on the CMS MIPS cost measure list. Hard to imagine that at some point the formula for costs for the ACOs won't be affected by the kinds of things that are coming out on this list. STEMIs, colonoscopies. Really, the cost of colonoscopy is a highly focused anesthesia cost variation. So it's interesting that that would be on the list. There are other cost measures that are on the new list. Chronic kidney disease. A lot of additional conditions are on the list for being tested this year and application over time. So what was once maybe a dozen cost measures, now 29 cost measures, soon to be probably 30 some cost measures. So this is a growing concept of how to economically measure costs that is on the payer side. So what happens with these cost measures? Well, they feed into a MIPS score, and our clients who are on the higher end of the spectrum could find their great quality scores diminished in incentives because of their costs. It's 30% of the total MIPS score. ACOs, to be able to grapple with this, especially on the specialty side, are going to need to grow their data expertise and solutions, and especially move into the arena of developing, along with the EHRs, a way of accomplishing the additional data that is going to be surging into the EHR databases. It will include genomic data. It will include a lot more data related to AI algorithms and natural language processing, which will take all of that unstructured data in the ERs and unleash it we will have huge more information in the EHR databases to be able to fit into these solutions. On the specialty side, that will be extremely important because it's 40 to 60% of the total cost, and ACOs in global cap will need to develop a mechanism to guide the distribution of those dollars to specialists. So there will be a choice on whether you aggregate all of the data. I'm really pleased that we see a high percentage of organizations selecting EHR data aggregation, because the choice on data aggregation will last for a little while, but there will be financial consequences for those organizations that aren't using all of that data, aggregated data. And that's bringing us to our questions and answers.
Okay. Well, we thank you, Terry. This was very informative. Obviously, folks, there's a lot here, and a lot of material that we covered today. So, some of you may be sitting there not even knowing where to start or what questions to ask, and need to absorb some of this. But if you have a question, go ahead and submit that now. We're going to get to as many as we can. In no particular order here. The first question is. For ACOs comprised of small practices, is it really feasible to gather all this data?
It is feasible to gather the data in certain formats. Almost all systems have mechanisms EHR systems have mechanisms to export data via reports. And those are, um, known as flat files, and to organize that data. They may not know how to do it. So having an application that an organization can use to feed that data, or to attach a FHIR API to that data, is the way to go. I'm definitely no longer looking at complicated interfaces to get data out of systems. That it has to help the providers not be burdened with doing anything that is expensive and complicated.
Yeah. Okay. Next question here is it sounds like you consider, quote, quality data to be about everything in an EHR. Are you really suggesting that ACOs gather full clinical data on a patient for them to do data driven strategies? And wouldn't that be horrendously expensive?
No, data is not expensive necessarily. Um, Getting data out of in difficult formats is expensive. For example, QRDAs are a more expensive format to get out and process, because they have to be converted from the format of the quality reporting into usable data. But no, it's not that expensive, and there's a lot in EHRs that, like imaging, that doesn't need to be collected. There's a lot of back and forth communications, obviously, that wouldn't be collected. It's what you're collecting are basically metrics and values, and those are just data points that are easily coming in through feeds, and we collect thousands of providers a month to be able to do that, and economically. And the more your ACOs are on a single system, the cheaper that data is, because you just have to do it once. The more electronic it is, the cheaper that is to do it. But I think the other thing to remember is that the ACOs themselves don't need to build and host a database. What they normally do is hire somebody to create the applications, to feed the analytics back to them, and show them what meaningful data they have, and to conduct all of the necessary projects that they want to do with that. So, for example, what we provide is we do all the episodes. So when we collect the data, we feed them into episodes. We provide all the episode analytics back to the organization online, and we provide them with the intervention populations for every patient who falls into their desired intervention list. So if they want a project to help patients with poor indicators in metabolic disease and come in on a faster schedule, or be lined up for glucose monitoring for diabetes, then we would provide them already with the patients that should be contacted and managed to be able to do that.
Okay. Next question here is, what do you think of the idea that by the time ACOs really are pressed to leave fee-for-service, that artificial intelligence can develop all the tools to direct and suggest better data-driven strategies?
Well, I think the AI is going to be an extremely important asset as we go forward. Right now, it's mainly on the actual medical side. So, imaging. If you look at the AI algorithms that have been approved by the FDA, they are almost all in radiology and imaging. The heart is coming up, ophthalmology is coming up, but few specialties really have AI algorithms to guide anything. So it's all diagnostics at this point. And there is very little AI happening in actual value-based care for cost. Now, will it? Yes, I think you will see activities, especially the most important activity that I think we should be focusing on is how we develop predictive patient risk with an AI algorithm. That could be enormously expansive in terms of identifying a variety of risks that we're just simply not appreciating. But yet we see it in the data. We know patients with depression don't always manage or have the best outcomes in diabetes and hypertension. That we know that there are relationships between the different conditions that patients have. That needs to be developed through AI type algorithms to see exactly what those are. And I think it will be beneficial, but no, it's people who actually make this work and physicians who are actually practicing who have to be engaged in this.
Okay, good deal. Well, that is all the time we have for today. So if you have a question again that you would like answered, go ahead and submit it even as we're wrapping up, and someone will reach out to you. But right now, Terry, I wanted to thank you again for this presentation. We are going to have a part 3 coming up. So some of you, we actually had to move it to from the 1st of May to the 14th of May. So hopefully if you already signed up, you get a notification. I sent out an email, but would love to have you join us there. And we'll send a thank you email out for this. That'll have a link to where you can register for that, as well as a link to the recording and the slides for you to download. So thank you again, Terry, so much for this presentation. As we wrap up, I'd like to encourage you all to head over to vbcexhibithall.com, and you can check out the Roji Health Intelligence virtual exhibit booth that's there and learn a little bit more about them. Terry, can I have you go to that next slide?
You see it?
Yep, got it now. And there's a lot of really cool resources there. You can read up on them and what they're doing. Of course, connect with the team there, or I'm happy to facilitate an introduction for you as well. And there's a lot of great archive material in the library, as well as it's going to be this webinar and a bunch of other webinars that Roji and others have done. So on a variety of topics. And then finally, if you'd like to reach out to Terry directly or to the Roji Health team, you can do so. On this last slide has their information here. Leonard Ho will take care of you and direct you in the right way, or you can reach out to Terry or again to me, and I'm happy to facilitate an introduction for you. Thank you all again so much for your time, for spending the afternoon with us. Thank you, Terry. I hope you all have a wonderful rest of your weeks. Bye-bye.